morning, good afternoon, good evening, everybody. Thanks for joining us. Today is an interesting topic we're going to cover as part of the COVID dialogues. My name is Junaid Razak. I work at Hopkins and I work part of my time at AKU in Karachi. And today's topic is, as you probably know, is the issue of stigma, fear, and the impact on care, especially, and then, for us in many places, the dead on arrival to the emergency departments. So I have today with me two really outstanding panelists with a lot of experience in emergency care. Professor Lee Wallis, he is Professor of Emergency Medicine at the University of Cape Town. He's also Chief Operating Officer at the African Federation for Emergency Medicine. Those of you, I'm sure many of you have heard his name. He has had a huge impact on emergency care, not just in Africa, but globally. So thank you, Lee, for joining us. The other speaker is Dr. Seemin Jamali. She's Executive Director at the Jinnah Postgraduate Medical Center in Karachi, Pakistan. She runs a very busy hospital, large hospital, and is, in my mind, is the face of emergency care in Pakistan. So thank you both for joining us, and we look forward to learning from you and exchanging ideas with you. Now, before I invite Lee and then Seemi to present, I just wanted to share with all of you this one slide. And this is a conceptual framework, and I really liked it. It was recently published at the as part of Addressing Stigma report in Canada. And as you can see, there are, this slide talks about the drivers of stigma, such as stereotypes, the fear of contagion, which is what we are dealing with in COVID, unequal power dynamics, lack of awareness. All of these are drivers of stigma. And then if you look at the types of stigma, you can see that there is stigma targeting identity, usually based on race, sexual orientation, gender identity, age, etc. And then health-related stigma, such as mental health, substance use, TB, and in this case, of course, COVID-19. And then moving on to stigma practices, and I feel like we are actually seeing a lot of that, discriminatory policies, behaviors, norms, demeaning languages and portrayals, social avoidance and exclusion by others, very important. And then we are, I've heard some hate crimes, assaults on patients with illnesses or families with patients with illnesses. And then that leads to experiences such as unfair treatment, anticipated stigma, secondary stigma experienced by friends, family, and caregivers. And finally, all of this leads to reduced access to care and quality of resources and health services available to these patients. And many of them have poor mental and physical health. So these are various points where you can intervene in a society at the individual level, interpersonal level, institutional level, and population level. And I feel like for COVID, our communication has been such that on one hand, we are giving too much responsibility to individuals for protecting themselves or getting infected. And those who get infected feel like it's a personal failure on their part. And then we have stigmatized this disease as this person with infection is now a problem for society and for healthcare system. So obviously that has impacted many of the care-seeking decisions. I'll just very quickly mention one of the cases that actually a phone conversation that I heard on social media. It's not from the US. And in that conversation, a family member a physician was trying to convince another physician, and that physician had signs, symptoms of COVID, to go and seek care. And that conversation actually was quite powerful, because this ill physician is telling this other colleague of his that he doesn't want to go because he doesn't know how the neighbors will react, and he has family and daughters, and he's concerned about them. And then a couple of days later, the physician, pretty senior physician, died, unfortunately. So you can see that this person was short of breath, was needing care at that time, but did not seek care primarily because of stigma and fear, and ended up with a poor outcome. So with that context, we decided to have this conversation with two folks who are at the front line in two different setups, and hear their thoughts. So as you know, while Professor Wallis is presenting, this is the email to share your ideas, your thoughts, as well as any questions, and we will ask those questions to the panelists. So with that, I would stop sharing and request Professor Wallis to please go ahead and present.
Thank you very much. Good day, everyone. Good morning, afternoon, or evening. So I was just before we started this, we joined a few minutes earlier, and I was just sharing a story in my responsibilities here in the Western Cape from Cape Town. I have leadership role in a province that has 6.5 million population, covers about 500 kilometers in each direction. And I have 300 ambulances as part of the government service. Last night, we'd had a positive staff member in an ambulance on Saturday, and we'd done the correct disinfection following the well thought out and evidence-based policies that we have around PPE and IPC. But the night shift that came on last night refused to go to work at all until all ambulances were properly disinfected and what they thought was sterilized, which talks about the fear that is in our community. And this is the well-educated part of our community. This is EMS who are on the front line. They've spent 3 months now being educated on an almost daily basis about this condition. And part of the reason that they behave like that is the fear of the disease, and part of what drives that is the stigma that goes with the disease. So just a little bit of background to frame the conversation. So there's a great website which I'll share onto the Google Doc or maybe Professor Razak can share with you afterwards, that has every country's data on it. And you can see, hopefully it's projecting well, you can see that if cases double every day, this would be the line that you follow. And every 5 days you follow in a line here, and every 10 days you follow in a line across here. See, South Africa, our current doubling rate is about every 7 days. So this is our total cases up until the 15th of May. Most of that outbreak, we're on about 14,000 cases today. Most of that is driven by my province. We are well ahead of the curve. Most of the country is flat. We're on 10,000 cases today, and we are not doing a great job of testing. It's not from lack of system to test, it's lack of reagents because of the introspective policies of some high-income countries' world leaders, shall we say. It's very hard to get reagents and tests. So while we're trying to test, we can't. And I think many African countries, you can see a lot of them on there. So many are on reasonably steep curves, and some are on fairly flat curves with different policies. This is the death. It follows a similar sort of pattern. You won't be surprised. Our deaths here are following about a doubling more or less every 7 to 8 days. And you'll see there's a whole range from Algeria, which peaked, one of the first countries, peaked quite early and seems to be flattening off, to countries that are on a steady part of a climb, and we're expecting more of an exponential rise. The London School, Imperial College London, excuse me, did some modeling about a month ago looking at African countries and predicted that the 10,000th case in South Africa would be mid-May. we were a little bit ahead of that, and that the 10,000th case in each of the 50-some countries, they put a date to it. So the rollout across Africa is really expected to hit over the next several months, with the last country, which I think was either Mozambique or Madagascar, is predicted to get its peak sometime only at the end of the year. So from a continental perspective, we're expecting this to go on for several months. And Cape Town, our modeling says that our peak will be the end of June, but then the downside, the sort of down curve of the peak is predicted to go through July, August, and into September. So we don't expect to return to normal health services this year, really. So this is what we live with in South Africa, but also more generally in Africa. And I guess all of you watching this could relate to this. It's a balance, how we've responded somehow between saving lives and responding to the outbreak and scaling down other health services and the sort of minimizing the short-term impact of the pandemic, balanced against things like the economy and the longer-term consequences and poverty and malnutrition and lack of education and all those other issues that go into it. And I think obviously all countries are struggling with that, but the struggle in Sweden and the struggle in South Africa and the struggle in Mali are not the same. And we're somewhere in the middle here, that we have decent resources, not good resources, but decent. But we have, in a province of about 6 million people, we've probably just pushed 2 million people over the poverty line by the very aggressive lockdown that we've done. So our projected impact from this pandemic, obviously we have a higher, we're expecting a higher rate of death with a higher age, and we're seeing that both in pre-hospital and inside the hospital. But what's mitigating our impact is the variability in health systems. So the private sector caters for about 15% of our population and about 5% of Africa's population overall, and provides what you might say is better care, although the access to critical care is very limited across the continent. The social circumstances, so we have a lot of overcrowding, we have townships, we have challenges where we discharge people with a positive test, but they go back to a shack where they're sharing a space smaller than my current office that I'm sitting in with 7 or 8 other people, and you have to work out how to quarantine or isolate people there. There's a lot of unemployment anyway and poverty anyway, and so we're obviously worsening that impact. And then just in terms of how effective a lockdown can be, we're sitting with a population here, we're telling them that this disease is going to make them very sick or kill them, but they've lived through apartheid in South Africa, but for the rest of Africa, they lived through HIV, TB, they lived through malaria in many parts of Africa all year round. Ebola outbreaks, similar outbreaks. DR Congo just had the world's biggest outbreak of measles, running at the same time as the second biggest outbreak of Ebola, and then they get COVID on top. And when you say to people, you know, we didn't really do much about measles, but you should worry about COVID, it's hard for them to take you seriously. In South Africa, with violence, we have our townships where on a daily basis, more people are killed from violence than so far have been killed from COVID. So when you try and persuade them that they should be part of a lockdown and socially isolate, it's hard to engage people. And then essential services and food security obviously is a big consideration, how you get people to engage in the social distancing and the other lockdown practices that you want them to get into. So we have a lot of income inequality, and communities have suffered a lot. And as a result of that, there's not much trust in the health system or in politicians. And this outbreak so far, it's showing injustices. So just as a tangent, the other part of my life, I have a farm with a guest house and a restaurant and a winery, and we employ 40-something people. And we, from a purely business point of view, we've never needed to do that, but we've tried to be as socially responsible as possible and employ a lot more people so they can support their families. The day we went into lockdown, I closed that down. I laid off every single member of staff, apart from one person to do essential maintenance on the farm. And that's 40-something people whose families now have nothing. They have no income. They have no food on the table. And but with no income, I could not possibly pay, because all of my businesses are closed now for the rest of this year. That's it. So if you amplify that multiple times, millions of times across the country, we have a big problem. And in the African context, it's similar, but on top of that, problems that we don't really have in South Africa. There's already a really deeply entrenched problem with stigma and discrimination, and many African countries have very repressive laws against groups that lie out with the norm, whether it's sexual or gender or race, color, or religious orientation, or how you can take your pick from many different areas. There are deeply entrenched stigmas and discrimination, some of them that are even regulated and legislated. There's very low levels of health literacy, governments that do not have a track record of effective communication, and certainly don't have a track record of accurate and truthful communication. Building on dysfunctional health systems with a very small private system, and then you try and put onto that this social distancing, mask wearing, hand washing, when people don't have access to water. You have one standpipe providing water for 70 houses. How do you do regular hand washing? So in the context of all of that, anyone who becomes positive is going to face incredibly difficult social and reintegration experiences. And we see that, again, Cape Town is not like the rest of Africa, where we're in many ways much better off. But just a few examples of how we are experiencing things that then would be amplified much worse in many African settings. If we have someone test positive in a hospital setting, basically, if they live in a township, we cannot reintroduce them, partly from their living conditions, but much more from, we've had people who, their homes have been burned down, they've been beaten up, their families have been run out of the area, their belongings have been destroyed. We've had health workers even who are not allowed to return home. We have police officers who are not allowed to return back on shift. None of that is from with the employed staff. It's not from poverty, it's not from lack of literacy or education. It's purely driven by fear and stigma. I just want to show you, just while I have slides on the screen, that any of you are interested in some materials specifically oriented to low resource settings. We've provided some through the African Federation, and I'm happy to share them with anyone. Sorry, Junaid, I guess I ran over there, but I will stop sharing my screen and hand over.
Great, thank you, Lee, for raising lots of very important issues. Again, everyone, before we have Dr. Jamali come in, I would just want to quickly share with you the email for the questions. It's coe.te@aku.edu. So our colleagues at AKU will get those emails from you and then forward it to us. So with that, Dr. Jamali, if I can request you to please share your thoughts on it.
Thank you very much, Junaid. Can we get into the slides, please? So thank you very much, Lee. It was brilliant hearing you. And I feel that, it's going to be a repetition of what you have said. I feel that whatever I wanted to say has come out straight from you. And there is a lot of stigma, fear, and of course, there is a very low level of, literacy, health literacy in our country as well. And a lot of people live below the poverty line. So it's more or less the same kind of things that we share. And there is such a lot of stigma in our country that people do not want to reach the hospitals, and they do not want to get to the hospital so that, people do not learn that they have this disease. And then if they die, their bodies would not be treated the way they are. So the disease is obviously very new, and it has people have stereotyped it, discriminated against it by treating people,
I'm sorry,
giving them.
Seemin, we can't see your slides. Do you have your slides on?
Yeah.
Can you share it again, please?
Can you see it now?
Sorry.
Are you there
No.
now?
No. Maybe it's going to, yeah, I'm seeing something happening now.
Can you see it now?
Yes.
Okay.
Thanks.
Right. Okay, sorry. So what I wanted to say was that we do not understand why people have made it such a stigma, given it such a stigma that maybe they have no knowledge of this disease, or they don't know what's going to happen to them. Surroundings are unknown. There's no cure to this disease, or maybe they are scared of the transmission, how it takes place. They're afraid of the unknown, absolutely. And it is easy to associate this fear with the fear of the unknown, basically. Things that, maybe generating the stigma, fear, and anxiety would be like, not being familiar to this. People who have tested positive, they don't know what the impacts of this disease would be on them. Then there is no knowledge, and there is a fear of the unknown, what's going to happen in the future. Transmission at workplace, especially for the healthcare workers, they're also scared to work here. Nobody wants to work ideally in a COVID ward, and it is very difficult, to tell them to get into the COVID ward and be there. Although they are trained, and we have been telling them time and again, giving them ample of training, abundant precautions how to exercise that, but even then people do not want to work there. Then there's a lot of misinformation and disinformation amongst the common man, and there's ignorance about the emerging virus, misconceptions, and a lot of myths that are associated with this. Then also there is a fear of dying alone. That is one of the biggest fears that I see, and I have a personal experience of my husband suffering from COVID recently. And it for a minute I couldn't although he's a professor of orthopedics, and I couldn't get myself to familiarize myself with the fact that, oh, he's got it now. Although I knew, I diagnosed, and I thought that it could be leading. The PCRs were negative 3 times, but then and I knew about it, that something was growing, but there was a fear. And when I can have that fear, I know that other people, the common man, has it. And then so many things run through your mind at that time. It's pretty scary, you think about it and it's pretty scary. Then you hear so many conspiracy theories. There are so many conspiracy theories going on in the world about this. People say that it's a virus that is generated through computers, through other things, and anything and everything could be that virus. So scientific misconceptions that block your mind. So I think those are some of the things that are some of the factors that generate this stigma. Excellent. That's good. Sorry. We'll move to the next one. And so the sufferers, like there's a lot of negative impact on the caregivers, and especially on the family, the friends, and the community as a whole. Anybody who they make you feel isolated. And even people tend to abandon their loved ones, because we see in our wards what happens is that people just deposit them over there, and they feel that they're not going to be able to see them, and they just leave and go. And we have been dialing the numbers time and again. If their patients somehow succumb to the disease, then we need to keep on dialing and redialing and keep on trying to communicate with them, which is very difficult at such a time. Sometimes we need they write about their some people say DNR or something like that. We need to take their approval prior to their coming in, because you don't know what happens to a patient, and every 2 or 3 hours they're updated about their patients. But even then the attendants disappear and they don't want to be here. Now this is culturally it doesn't happen normally in our country, because they bring 10 or 15 attendants from their homes when they're coming to hospitals. But in these circumstances, they just disappear. And people don't want to tell about their illness. They don't tell people. They discourage them from adopting healthy behaviors. They don't seek health care initially. They have these excluded, because they feel that they're going to be shunned or excluded from the social situation. They're denied healthcare. And also in our private setups, there is another huge problem that we see, that the private setups do not want to take these patients. They refer them to the public sector, and only a few, I can just say one or two private setups take it, and that also if they have beds available. In Pakistan, AKU is one in Karachi who's taking some of these patients, and another one. Other than that, no private setup wants to take. And as soon as they feel that the patient has come with fever and upper or low respiratory symptoms, especially with cough, they just say that, okay, you go and get yourself tested, otherwise we can't take you in. So that is one of the huge problems that comes up over here. Then the impact on the healthcare workers is also tremendous. They do not want to seek healthcare at all. And the pressures that are on the mind, the physical and the mental stress that we go through. There is compassion fatigue. There is burnout of the healthcare workers. The fear of contracting the infection from workplace is also there. The stigma that related to the stress also, efficacy and self-esteem, that is very undermined. And then you have no acknowledgement. You keep working and working and working, and there is no acknowledgement. There is no policy of looking after the welfare of these healthcare workers, especially if you die in the line of duty. Then there is nothing to acknowledge you. And in the process, we have misplaced anger, we have hostility. People have a lot of hostility towards the healthcare workers, and this hampers health provision of health to the common man, because they feel that we have kind of become responsible for this. And in certainly no way we are responsible, but they feel that the healthcare workers have enlightened them about talking of this disease all the time, and they get angry and they misplace their anger. So they have so people who come dead on arrival in the hospitals. There are a lot of people recently we have seen, because of the lockdown, we saw a lot of people coming in dead on arrival who were not who did not seek health care. And all these people were not due to road traffic injuries or gunshots that we normally have, or assaults, but we saw a lot of people coming in dead to the ERs because of not seeking health care, either because it was the last resort for them to come to the hospital, because they thought that they will contrive any illness from the hospital, or last minute they would want to just come to certify whether their person was dead. And the number of patients also, as I had told you earlier on, also the number has come kind of decreased tremendously for people coming into the ER as well as to our outpatients department. And anybody who has underlying medical illness, some of them who are literate could communicate with telemedicine or through telephonic systems, but otherwise they do not want to get to healthcare workers. And words don't really matter when you are talking about this. We as a nation, people try and dehumanize people. They don't want to use the right terminology. They stigmatize. Our own people do it to themselves. They have sent videos on the social media that are totally irrelevant, that never needed to be sent. They emphasize. We have been emphasizing on the preventive measures a lot, but there is barely any treatment that you can give them, only that, which is also symptomatic. Speaking about, we try and speak to them about the social stigma, but they, because of the illiteracy in the country and, a very low literacy rate, people do not want to understand that. And geographically and culturally, we have also seen that people do not want to see their loved one die like this, or they feel that they don't want to leave them alone in the hospitals like this. They don't want to. So if they see these people, they recover, then there would be some support, but otherwise they would just, abandon them and go. And a lot of things that I say are also because of the journalist community. The media has been, kind of misrepresenting facts. And sometimes, sometimes they don't represent the facts accurately. And they have this adventurous journalism kind of techniques, which I think now need to be stopped, because you can't, uh, in a country like ours, which has the Islamic cultures, the shrouding of the dead body, the burial procedures are so different from what they would be in the West, and I think that is one of the things that complicates everything. So there are a lot of rumors, there's a lot of misconception, there is a lot of misinformation, and that contributes to the discrimination and stigma, and it hampers the response efforts as well. So I feel that now, there is time that we communicate to people, we support each other, we encourage people should encourage the frontliners. Only in our hospital that we have seen lately that people come and if a person dies right after arrival to the ER, they start bashing up the ER or the wards or the units, and then they like feel that these doctors are responsible for killing the people, although they have brought them to the at the last minute and at the brink when they're just going to go off. So they assault the doctors, the nurses, the paramedics, and that's a huge problem for us. Here I would just like to show you a little video where these people had where this in this COVID ward, which is very separate from the rest of the hospital. Okay. And people just barged into the room because one of their persons had died, and they wanted to take the dead body away. And in the process, they broke the door open. See how they will come in, and they've kicked and they have beaten and they have got violent because they know that the body would be handed over to the DHO. And this was all seen in our place. What happened? They beat, assault, and whatever came to their hand, they threw it onto people, and then they continue to do this. And see how they're breaking the door, and they bash the chairs and break the window panes and the glass and the computers. They damaged everything, and then in the process they tried to take the dead body out, which was covered, wrapped in body bags. And they just want to do this. They do it. They come in mobs, and they want to take their loved ones away. And the system is very difficult. You have to communicate with the DHO, and that's why I say that we need to revisit and evaluate how you want to give away the dead to their loved ones, because this cannot go on for long. This is just one hospital. I've shown you one of our hospital. With the other hospitals, the same thing has happened into several other hospitals. They beat, bash, and then they take the dead away. And unless somebody, even the police can't control them. So it was very hard for us to counter this. As doctors, you can't do it. You're not trained to fight them, and even the security couldn't put them in place till we had to call out the law enforcement agencies. So these are the kind of things that happen. So I think people now in our country need to revisit the way of burial, the way of handing over the dead to the way they are shrouding them, the way they are going to be given back to the family. So that's about all that I want to say. There's a lot of um, a lot like we have kind of have had more testing in our country now. It's there's a lot of more testing than what we had seen in the initial numbers, and of course we have less testing kits, but now that they have come in, we can do quite a few tests now of the people, although not sufficient enough, but still not bad. There are certain hospitals that have been designated to do the tests. And then we have these isolation centers where you just isolate and quarantine and put people away. But there is there's only so much that you can do over here in a country like ours. These tertiary care hospitals in the public sector are the only ones that are dealing with this, and that's it. That's it.
Thank you.
Thank you very much.
Yeah, thanks, Amy, Jamali, and thank you, Professor Wallis. Wow, these images are very, very concerning. So if, I have a couple of questions, but before I do that, if you, Seem if you stop sharing, and I'll again share my screen with the email so people can write us questions. So again, for everyone, please feel free to write your questions on this email. So in terms of, I want to first address the healthcare workers and the fear amongst healthcare workers. And Professor Wallis you mentioned that your experience recently with EMS crew, and every day when I go to work, I also have that sense coming back home, am I bringing something for my family? And Dr. Jamali mentioned about her husband. So how do you communicate? Something is not right? I mean, all of us, knowing so much about this, are very, very fearful. How do we address that? And if we start losing some of our healthcare workers, which are closer to us, what impact could it have in healthcare delivery? So maybe Leah, I can ask you first, and then Seemin, you can go next.
Thanks, Junaid. It's a really important question and something that I think can only be answered right at the front line. So I give two examples from here where I think we've handled it differently with very different results. And going into that, what we've had is not a lack of communication. We've had just way too much. I don't know what it's like where the audience work, but we have a series of Western Cape government health circulars, and by the 16th of March we were on number 7 for the year. We're now on number 81. So we brought out 74 circulars, most of which are between 10 and 50 pages long, covering everything. So we are policied up to the eyeballs. We are covered. Everything is done right, but no one's got the bandwidth to read these things. No one, they don't filter down to the front line. So a lot of the fear is expressed in how people use PPE. And we have great policies that are informed by World Health Organization, CDC, and other really reputable bodies like that. But I went to a small rural hospital about 2 weeks ago. There was a infrastructure issue we had to try and fix there. And as I was walking around the hospital in the non-COVID part, everyone's wearing N95 masks. And we have a real supply chain problem with them. And our policy is very clear that you don't need any form of PPE, just normal PPE for the non-COVID patients. So, if you have TB patients, whatever, but surgical ward, maternity ward, they all had N95s. So I asked the hospital manager, what's going on? Why do you have your own policy? And he said, no, the staff won't come to work if I won't give them N95s. They refuse to come to work. And actually, over the weekend, just over a week ago, they didn't have N95s and they downed tools and refused to work at the hospital. So it's not that we didn't have the communication or the well thought out policy. It's that the staff were still afraid. And in the EMS service, we've had several episodes of downing tools, mini strike action, because they want full PPE for every patient, because they say they don't know if this patient is positive or not. And they're absolutely right. We don't know if the patient's positive, but our policy says, if they have these acute respiratory symptoms, you do this PPE, and otherwise you do this PPE. So we've had staff going on strike through that. So how we've dealt with it differently in the hospital, the hospital manager tried talking to staff and they weren't interested, but he got the family physician on board, and the family physician is really well respected. He's a champion in the hospital for many things. He has the support of the junior staff and the nursing staff, and he just went around more or less one by one and spoke to them and sat staff down and said, what's bothering you? Why are you scared about this? So not a group thing, not a policy on paper, not a lecture to people. Went person to person and spoke to them, took a long time, and asked people individually, what's bothering you? What can we do to make your life feel safer? And some of them are still wearing N95s, but mostly they're following the policy. In EMS, we took a different approach because they were being very militant. So the leadership took a militant approach. got them all basically in a classroom and spoke at them. And some people who were allowed got their questions heard and not answered in a very satisfactory way. And so not surprisingly, our EMS problems continue. People didn't hear that. I think the answer is that we need to, as with effective communication, you need to do it on a one-on-one basis. You need to listen to people. You need to be seen to listen to people. And you need to be responsive to their individual issues.
Seemin?
Yes, I think, Lee, I think it's wonderful, to learn from you because we have so many similarities. And I think that exactly what you've said, but when it was the first day when we had received a patient, everybody and anybody in the hospital refused to work completely in a staffing of about 2,000 people. They just came up and said that they were not going to work bless you, without a PPE and an N95 mask. So if they did not have an N95 mask, they did not want to work. And especially the people in the COVID area, we did supply them with everything. But in the general wards, it was difficult to supply so many PPEs. But then I thought that, if people would go on strike and people would refuse to work, I think it would be very difficult to contain them then. So from day one, we decided that we're going to give them all PPEs, and we had talked to them in person. But in our community, people do not listen. They think that we're trying to convince them not to use the mask. So I thought that the best way out is to let them have the PPE for their comfort. Even if they wear, what they do is to put on the mask and put it down on their neck after a bit, which is very funny for me. But that's the way they treat the mask because it's difficult to continuously wear it for a while. So I think the same thing has happened over here. We have to be talking to them again and again. If you talk to them one-on-one, it's very difficult to talk to them one-on-one. But every time now that we have these new physicians coming in for a change of rotation, we talk to them separately, individually, and tell them and ask them about what their fear and fright is. And mostly it's about people think that they're going to take this infection back home. They have elders living in their homes, and that is one of the big problems. So we have tried to arrange some accommodation for people, who are going to stay here in the hospital. And there is, you see that there is still a lot of fear amongst people. Somehow, at our age, we're not so frightened to, continue this work, but the stigma is so much and people feel so frightened. And you would be very surprised to see that nobody from our isolation or emergency room, nobody got this infection. It was all the other people who got it in the hospital, all the ones like the surgeons, for example. The surgeons are not so acquainted with all this, and they were in the kind of, they were not doing routine surgery, but of course they had to do emergency surgery. And how my husband got it as well must have been very well from some patient or from the community spread. The community, I know he doesn't want visit, but it must be from a patient. So now the doctors are saying that any person who's going to be operated and will have routine surgery for anything is going to be tested for COVID. I don't know how beneficial that would be, but I think at least it will get some fear off their mind and off their chest.
The second question is from Dr. Nico Risco, and it's for you, Lee. Dr. Wallis raised the problem that projected health impact of COVID may not be as significant as other endemic conditions such as TB, malaria, HIV, etc. Yet the economic shutdowns are doing immense harm. Are any public health leaders breaking from the pack and speaking out against lockdowns? Or should we maintain a unified voice and continue to recommend aggressive distancing?
Hi, Nico. Didn't realize you were listening. You, I'm sure, could have done a good presentation yourself on this. Look, there's no. Are there some public health people speaking out against? Yeah, absolutely. I'm sure you can find everything on Google. Here we have our South African response is led by a series of ministerial advisory committees. So each main ministry has their advisory experts. And in health, we have some really top-class world leading people advising government. And they've been a unified voice behind the need for the lockdown. What they've started breaking ranks on now is we have a very aggressive lockdown, but we have some stupidity in it. So I think most people really support the principle of the lockdown, but when it's at the point of you can't buy alcohol, we have a prohibition, and there's reasons for that around social distancing and the behavior when people have alcohol. But you can't buy cigarettes either, and no one can give a real reason for that. You can buy winter clothing, but you can't buy t-shirts. You can buy shoes, but you can't buy open-toed sandals. So people are really starting to. So the head of our medical research council is one of the most respected physicians in the country, spoke out at the weekend saying, we should continue this lockdown, but we should do it with evidence and stop being crazy with the sort of things that we're doing. And I think that's going to happen more and more. We're now day 52 of complete lockdown. So I think we're going to see that quite a lot more in this country, and as countries get into lockdown fatigue. No one's made the real, there are a few people have sort of presented some opinion pieces saying, the longer term toll is going to be very significant, but no one that I've seen has come out and said, therefore we should stop what we're doing. They've just said we need to do what we're doing, but also at the same time start making aggressive plans around TB, malaria, malnutrition, poverty, and those effects.
Great.
So I don't think it's an either or. Sorry,
Yeah.
Julie.
No, thanks, Lee. I wanted to take this same sort of taking from the point you just mentioned to Dr. Jamali, where in Pakistan the immunization, people who were going house to house, community health workers and those who were doing vaccine program, immunization program, many of them were targeted, and that has led to poor immunization rates. Now with COVID, these public health programs will get significantly impacted. And Dr. Talha from AKU is asking, how do you think LMICs will recover to go back to routine immunizations in this situation?
So, Junaid, I really don't know now because the immunization programs have been, kind of hampered. The polio program is quite hampered, and we don't have the polio workers now, coming in. They're very reluctant. Even if they try and go there, often they're beaten up or they're, assaulted by people over there. And I don't know with this business now coming in, how people are going to react, because as it is, they have, targeted hospitals and they're targeting healthcare workers. A big institution like this in our place, another one in Karachi, the third one in Karachi, all three of them, 4, 5, in fact, have been targeted. People have been assaulted. So I don't know what's going to be, how it's going to shape up. And the other very important thing is that I think there is no unity amongst different provinces. One says lockdown, one says no lockdown, one says, lockdown at certain point of areas where you're going to pinpoint these are the hotspots and you're going to lock them down. So nobody knows. And I don't even know whether, how much validity this PCR is having, that, in a minute you're PCR negative and then you say you're PCR positive. And then what are you going to say about this if you're going to, on the basis of the PCR, you're going to, target the communities. So I think I don't see a very good solution to the whole situation, because in our country, these hotspots are not easy to maintain as well. You go to a hotspot, you go and see there are people living in a small house, there are 15 or 16 people living in the same building or in the same 2-3 rooms apartment. So how do you, categorize? And those who have not got it will get it obviously over there. So it's very tough. There are small lanes. People, they thought that, after the lockdown, people would, be allowed to get out. Today, the Supreme Court has taken a huge decision in which, in Pakistan, the Supreme Court has ordered to, allow the markets and shops to be open, including all the malls. And they have also said that you need to carry out your SOPs. Now, God alone knows how they're going to carry out those SOPs in the malls. It's not so bad. It's not going to be difficult. But in these small shops and in the roadway shops, I think it's not going to be possible. Because I already saw, as I was, coming here, that people were, just hoarding on the streets, and they were all over the streets. And they said that, little children couldn't get out of their homes, and now, everybody's on the street.
Yeah. Well, we addressed the other question that Sala is asking about EMS and hospital. I want to come to the question by Dr. Amna Hussain from Hopkins, and she's asking, what measures can the government do that will be effective in displacing fears and promoting accurate information? Do you think government knows? Do you think government, they're human beings, they have so much information coming through. What can they do better? Maybe one of you can start, another one can chime in.
Well, I'd like to say this, that the government could certainly do better, because they need to, in our country. I'm just talking about our country and our province at the moment, because I see that a lot of people come to our ward, and there are many who die because they're seriously ill patients, and they do die. So the process of, sending them to the, I don't know if you understand this terminology, the DHO has to be called, and then the ED people have to be called, and the DHO nominates his subordinate to, take hold of the body, and the body is not handed over to the attendants. So a lot of commotion is created, and then the police needs to be there. So when all this is taking place, it takes about 2 to 3 hours. It's not like any other country. It takes about 3 hours for this to happen. And and there's no autopsy, obviously. So when this happens, people and the government knows that people are very agitated in that, and that is the time when this happened in our hospital as well. When they were waiting for the dead body to be handed over, they bashed in, they broke open, and I wish I could have showed you the second part of this video, in which they dragged their dead body out of the ward, and they were taking them away till the police arrived and got hold of the body. So I think that is one thing that needs to be, contained. The government should realize now that people are scared of this, and there is a fear of, being buried alone without your attendants, and it is not cultural enough. So you have to respect the culture of the country and the religion of the country without any discrimination, whatsoever they are, and they need to be, buried respectfully.
Lee?
It's a really important but tough question. I think the first thing is there's never been so much availability of information and communication, so we should be able to get the right answers. The flip side is there's never been so much availability of information and communication, so you can find anything you want to fit any narrative that you want. And how people are supposed to filter through that, we see very smart physicians posting garbage on social media because it's just overwhelming, and it's really hard to find your way through it. So expecting the general population to do that, I don't see how we can do it. I think government they have one responsibility in this, which is communication. And I don't mean too much. I mean really simple messages, but driven again and again and again. And I think for the most part, from what I've seen, all governments are doing a bad job of that. They're leaving it to the population to work out information for themselves, and that is never going to end well. On the flip side, I actually, while this is a new virus and a new pandemic, and there's some specific things about COVID, we know the answers to this stuff. We know what we should do, and it informs policy. That's fine. But we also know about behavior and human psychology, and we should be able to put together the right communication package. But I just think, particularly in low and middle income settings, governments are so overwhelmed by trying to manage the sort of social side of it and the public health side that they're just not focusing on communication. But it's absolutely critical. And without it, I think, like we're doing here, you lose the fight, and then people just give in, and they start to see that the public health side of it is less important than the other things, and they just go back towards normal life. I think the answer is just really protracted for the rest of 2020. We should be seeing everywhere you look, there should be simple one-line messages, infographics for people who can't read, stuff in your own language. Just having a paragraph in English in small font is not going to solve the problem. It needs to be simple. And I don't know this stuff, but this stuff is known very well by people how to do this.
Yeah, a question from Dr. Amber Mahmood from Hopkins, and she's raising this question around a one-size-fit-all message. You know, we should do X, and everybody should do X and Y, and not being context specific. And as you can see, her question is, what alternatives, context specific measures and equitable policies, strategies the local emergency and public health community could offer for such countries? I mean, I think it's a very complex question, uh, but anything that you would do differently from, say, what Sweden, South Korea, US is doing in your own contexts?
Yeah, well, let's not mention the US. I think we can pick several things that we'd do differently, starting with the voter station probably. Yeah, that's really hard to answer, not surprisingly. I think the whole of government approach and whole of society approach has to underpin it. This is not a hospital-based issue. So whatever the attack rate is, let's say at any time 90+% of your population don't have it, but a lot of them will need to go into quarantine because they're exposed, or they have this other impact on their life, and they need to wear masks and have access to hand washing and sanitizer and social distancing messaging. So there's all that side of it. As you get towards the health sphere, 90% of patients are going to be in primary care. They're not going to hit the hospitals. I understand maybe in countries like Pakistan, where the primary care system might not be as robust, then they do come to hospital, but they are primary care problems at the hospital. And I think you can orient your services such that that can be expected and dealt with, so that people don't need to come through the specialized emergency unit or the parts of the hospital with people who test a lot and spend a lot. You can put primary care clinicians as the front line, and they will turn away 9 out of 10 of the patients. And really the rest who come in, I think that when you're down to 10% of 10%, so you're down to 1% of the population in the hospital, that's actually, it's an expensive part, but that shouldn't be the focus. I think you can do a reasonable job of focusing on things in the community to keep people well, and then things in primary care to keep people out of hospital.
Thanks. Seemin, you want to add something?
Well, it's more or less the same thing, but unfortunately, in our country, the primary health are very poor. They're not so efficient, and therefore people have to come to the secondary and tertiary healthcare centers, and that's a big problem. And a lot of people in our country live in the rural areas. So in the rural areas, there's even less access to healthcare. So they have to come to the urban areas and urban setups, and therefore, they all land up into the larger tertiary care setups. And therefore, our numbers become overwhelming sometimes. As it is, we were an overused place. But now with this, I think we've left the rest of the diseases in oblivion. And it feels as if, the road traffic injuries, the firearms that we used to see so often have stopped coming to the hospital. All the other injuries and all the other medical illnesses, so much so that, we used to have 125 cases of dog bite in every 24 hours, 125. Now that's a big number for immunization. And at this point, we have half the numbers. So the dogs have disappeared. They're looking for human beings, perhaps. I don't know. I don't have the answer, but something is, or all the people people who used to come to hospitals regularly have stopped coming to the hospitals for other ailments.
Wow, as you can tell the audience, it's such a complex and difficult issue to discuss, and not just discuss, but get solutions to. We don't know enough. I think we're all trying to find better ways to do things. We are at the finish line. I just want to summarize some of the points that came out around the public health messaging, the fear of dying alone, the sense of healthcare workers feeling very vulnerable, population not accessing care because they feel that they might get infected. And when they get labeled, then this whole issue of policing around COVID and being seen they're seeing it as a punishment. Somebody gets sick. There's so many issues around there, which I think some of us who are in academia need to really help tease out and write about and think about. So with that, I'd like to thank you both. Dr. Seemin Jamali, thank you so much. I know it's a Ramadan and it's time for the end of fast. And Professor Lee Wallis, thank you so much for both of your time. And we'd love to see you again in this session.
Thank you very much.
And thanks everybody too.
Only a pleasure, Junaid. Thank you. And very nice to meet you, Dr. Jamal.
Thank you.
Thank you.